all we know about other people with this kind of fracture have different comorbidities like we're seeing here. We're not going to talk about that because it's only 10 minutes talk. Most hip fracture surgery goes very well. So why we should talk about this? Because even if most of them go very well, we can still improve. There is a failure of the oris in about almost 40% in unstable fractures. Not in stable, but in unstable fractures, there is almost 40% of problems. And when it happens, when there is a failure, the failure is very costly because it means to reoperate and maybe to change the devices or to make a prosthesis. And the cost is cost for the patient, it's cost for the family, it's cost for the society, and also cost for the insurance. Rule number one, you should know the fracture type. You should know which one is stable, which is unstable. You should not confuse because between peers with apples. So in the 3-1A1 to 3-1A2, those are stable fractures. The unstable are the 3-1-2 to 3-1-8-3. So those are unstable. So for a stable fracture, you can use plates, but for unstable fracture, you must use nails. You should know about the structural contouring forces, what happened with the proximal fragment that goes in abduction and flexion, and what happened with the distal fragment that goes in adduction, because of the adductor muscle groups, and the other one because of the gluteus medius, and the iliopsoas. Rule number 2, you should never leave this fracture in varus because it won't go very well. So this happened with this kind of fracture. If you leave this fracture in varus, it is probably that the implant will break, or we have another refracture or the pseudoarthrosis of this fracture, or because of this varus pain in the hip. And the principal way to avoid the varus is that you should put the shunt pin medial to the tip of the gradient trochanter. If you put it a little laterally, it will go in varus. So there are different works about that you should do. If you do a lateral starting point, it's similar to put this fracture in varus. So it must be just medial to the tip. And how to deliver a starting point like in this kind of fracture, you should pair it with a shunt pin using like a joystick. Here using a joystick, so you put it in a real AP view, and you can put a pin exactly medial to the greater trochanter. And that's the way to go. This is the final follow-up. Rule number 3, respect the lateral wall. What is the lateral wall? It's part of the pertrochanteric fracture. It's not a separate anatomical structure in a normal femur. Why the lateral wall is important? Because provides a buttress for the proximal fragments, allows controlled fracture impaction. Without it, you convert to a reverse obliquely equivalent. This leads to uncontrolled collapse. What does mean? Like this here. You have a good lateral wall, and these proximal fragments won't displace. But you have a breaking lateral wall. When you do this kind of implant, it will displace. Big hole plus non-collinear rimming is similar to lateral trochanteric wall fracture. That happens frequently, often because, why? Because this lateral wall is very thin, and you want to put like a dynamic hip screw like here. This almost 17 millimeters in the proximal part of this device. It happened to me. It happened to me. It happened to you. That you break this lateral wall, and also it is not. It is a 4-part fragment, so it is you convert it from a stable fracture to an unstable fracture. And if you put this device, probably it won't go well. So if there is no lateral wall, there should be no hip screw. Little holes plus collinear rimming means intact lateral trochanteric wall. So if you do little holes with this kind of plateless percutaneous compression plates, there won't be lateral wall fractures. Almost 2% compared with a sliding hip screw that is almost 30%. We don't have this kind of device in Peru, but I think it's a good way to work with if you want to use this kind of plate instead of a sliding hip screw. Number 4, reverse oblique fractures, always nail it. This is an established incidence of 5% of oblique intertectonic fractures, and the recommended fixed angle device is nail. It is expensive, but for the future, it won't be so expensive because it will be costly if you use a dynamic hip screw. This happened with a dynamic hip screw. If you put in an oblique fracture, it will displace. And those are different treatments for reverse obliquity intertrochanteric fractures. And how does it fail? If you put a DHS, almost 56% of this fracture fails. With a nail, long nail, 30%, with a DCS, 30%. And look at that, with a simple angle blade plate, 95 angle blade plate, 13%. If a nail, proximal femoral nail, is well put, it's almost 0%. So you should know the unstable intertectonic fracture patterns and nail them. Number 5, pick the right table position. There are different ways to do it, depends on what you have in your hospital. Lateral is beneficial with subtrochanteric fractures. Lateral is beneficial in the morbidity of this. This is the way we do with a C-arm. This is one of the positions for the C-arm. If you have all the conditions, this is the way we do it in the clinic with a C-arm, with the leg abducted and flexed. We can see in frontal and lateral in a good way. And in other hospitals we don't have a traction table, but we use the resident, the strongest one. He will be the traction table. Don't forget to put this device in the proximal part of the femur, so it will elevate it. Otherwise, you're going to see that there is not a real anteversion. You're going to be stuck, and you want to be in the lateral position with a good anteversion of this proximal part. In obese patients, it's better to do it laterally. Number 6, opening is not a sign of weakness. You're not supposed to do a biologic insult, but you can do open reductions directly or indirectly with mini invasion procedures. Opening doesn't mean that you have to commit a first-degree murder of the bone. You should gentle handling. You should place clamps without anterior strapping. Infernal fixation is not a good way to do it in this moment. It's a woman of 75 years old. You see that there is a fracture. We tried to reduce it with a traction table. It didn't go well. It was displaced. She made a little incision. We put a clamp, and then we fixed it with a proximal femoral nail, and that was a good one. We put a wire here, and the fracture was very good. Rule number 7: the tip apex distance matters. You know what is the tip apex index? Almost in the frontal and the lateral position. Normally it's less than 25 millimeters. If it is less than 20. It was talked by Baumgartner et al. In a search for nail or plate. The tip apex distance is for sliding screw and for nails. In the past, the professors taught us that the device must be low and posterior in the neck. Now we should avoid it because it increases the tip apex. It should be deep and in the center, 10 millimeters of subchondral bone. This is the way, exactly what it should be the nail or the DHS. Rule number 8: don't use locking plates. This is the injury. See the fracture. It was fixed with a plate, proximal plate, not the percutaneous one, and see that the fracture is very well reduced. the final follow-up, the fracture has consolidated, looks great, but in clinical series, you can see that this kind of devices can break, can go the fracture in varus, and 30% of these plates require more surgery because of failed fixation, for malunion or malalignment, or because of deep infections. And there are some risks for failure, like comorbidities, medial instability, fixing varus, or manufacturer plates. Number 9, avoid nail destruction. Do not traction so much, otherwise you're going to displace this fracture and the nail can break. Number 10, beware with anterior cortex of femoral diaphysis. In older people, the femur enlarge and bow. If you use curved nails, it's better to use curved nail than straight ones, because the straight one could pinch and perforate, and the distal screw works like stress razors and it can fracture. Never use hammers, and you have to beware with a iatrogenic fracture. Rule number 11, reduce the fracture, then rim. When you prepare the canal, if you don't reduce the fracture and you put the nail in this way, obviously the fracture is displaced. Probably it will heal, but this patient must have probably pain, because the proximal part of the femur must be anatomically reduced. So you should, before putting the plate, you should reduce the fracture, and then you can nail it. Rule number 12, try to reduce with positive medial support. What that means, there is an article about that. The positive medial support means that the proximal part of the internal cortex of the proximal part must be ahead of the distal part. This is the positive one. When it is anatomic, they're in the same level, and when it's negative, it is before the distal parts. This is the negative one. You can see it. It is behind. So in this kind of position, the slide can display. If you bring a positive one, that means almost in valgus one, in the valgus position. When it displays, it can touch here and it won't displace. Those are different types of fixation: in the negative one, in the neutral one, in the positive one. Rule number 13, do not forget the external fixator. I don't know if in your countries you use this kind of device for fixation of the intertrochanteric fracture, but in our country, we use it in some places because, number one, it's very cheap. It costs $150 compared for about $2,000 for the proximal femoral nails. We can do it in the percutaneous way. It is very easy to do it. It doesn't bleed. So you should never forget, because it's a way when in undeveloped countries for people that they can afford a nail. Number 4, if all else fails, use a nail to connect head to the shaft and lock distally. Like in this case, a gunshot, we use this nail, a proximal femoral. It seems like it was working. 6 months, the luck change. See that it breaks. We change the name to the PFN. It didn't work. Finally, we use a modular hip arthroplasty. Number 5, rule number 15, use threaded pins, not the smooth ones, because smooth ones can displace in that manner. This is not mine, but I found it. So you should take this. The patient didn't die, but he cannot move so much, I guess. Rule number 16, never use hammer. This happened to me. See, this oblique fracture, we put a nail, and I hammer it, and I break it. I break it here. So finally, we reduce it with a plate, but you should never hammer it. Number 17, not always the last is the best. See, in this case, we use a a plate like this. It didn't work. It is costly. And if you use a regular plate, an angle blade plate, 95 plate, it will heal better maybe with another plate. So this is my last talk, and I have to thank to the Indian Society for the invitation, and I hope you can be in Peru someday. We got that meeting in Peru in this year. I am sure that Dr. Torres has invited you to this meeting, and it will be a very pleasure to be with you here in Peru. Thank you very much.